Imagine you're a little girl in the emergency room. One second you are playing with your new favorite toy, and the next you're writhing around in pain. The doctors all gather around you and they know exactly what's happening, right? Well, they don't. As it so turns out, you're a 7-year-old girl who swallowed not one, not two, not even 3 or 4 small neodymium magnets known as buckyballs, but 37 of them. They ended up ripping 4 holes in your GI tract. You can ask Coach Goff. Stomach holes are not fun at all. And how did the doctors figure all this out? Well, they didn't. The radiologists did. So X-ray is a way for medical professionals to diagnose patients non-invasively, and that's how they found out this 7-year-old girl swallowed 37 magnets and ripped 4 holes in her GI tract. You could say that diagnosis is just a small part of the medical field, but you'd be wrong, because the medical field's all about diagnosing, and I chose radiology because I think radiology is the best way to non-invasively diagnose someone, and I think that the medical innovations that come with radiology are going to grow exponentially in the future. My name is Matt Lee, and I want to save lives through reading X-rays, CT scans, MRIs, and other types of radiological scans. Last year in ISM at the beginning, I actually wanted to study cardiology because I knew that cardiologists make around $500,000 a year, and I could be driving down the street in this beautiful Ferrari LaFerrari. But after some preliminary research, I decided that cardiology was not really for me. It just didn't have the appeal to me that it could be a job that I could do for the rest of my life. So I turned to radiology, and because I loved the visual aspect of it. ISM definitely gives me an edge over those who aren't in ISM, because how many people can say that they've had professional career experience even before going to college? Michael York once said, "I think that you have to believe in your destiny, that you'll succeed, you'll meet a lot of rejection, and it's not always a straight path. There's going to be detours, so enjoy the view." If you know me and my ISM story, you know that this quote perfectly describes what I've been through in the last 2 years. Last year I was actually the last person in the entire school district to get a mentor, so that was definitely the rejection part of the quote. It definitely wasn't a straight path, and there were tons of detours, but I adhered to the quote, and I learned so much information that I can't even comprehend all of it today. One of the biggest components of ISM is the research, and what we do is we look into research assessments, and we write papers about what we've learned and how we can apply it to our lives instead of just regurgitating information. These are some of the articles that impacted me most this year in my research. The first one was, "Radiologists face no elevated risk of radiation-related mortality." So whenever I tell someone I want to be a radiologist or I want to read scans of X-rays, they always say, "Be careful, you might get cancer." That's simply not the case. It's a common misconception that radiologists are exposed to a ton of radiation. This article highlighted a study that conducted with 44,000 radiologists compared to 44,000 psychiatrists. And what actually happened was they looked for radiation-related illnesses in both groups, and the rates were very similar. In fact, the radiologists were actually a little bit healthier than the psychiatrists, and they had no elevated risk of radiation sickness or cancer like that. So this kind of reassured me that even though everyone was telling me it's a dangerous job and you might get cancer, that it's really safe and it's a good career for me to go into. One of the ways I've seen this in my experience in Health Science 3 and ISM and Health Science 2 is these radiation detection badges right here. They'll have your name on them, and they'll measure how much radiation you're getting, so it makes sure that you have a safe amount that you're exposed to. The next article was called "The Antidote for Radiology Errors." I learned through this article that radiologists are actually sometimes punished or fined for making mistakes that are common and understandable, and I don't think that's how it should be run, because they fear the punishment, and it just makes it a situation that's really unbearable for radiologists. So this article highlighted some solutions that could help reduce errors besides punishing the radiologists. The first was the checklist solution. So if you're a pilot flying a plane, you have to go through the checklist and make sure everything's functioning perfectly normal so that you can take off and not put lives in danger. So like a pilot, a radiologist using the checklist solution would go through and check things periodically and in a structure. For example, Dr. Riley, my mentor, if he looks at a lumbar spine MRI, what he'll do is look at the spinal cord first, and then he'll look at the lining of the walls around the spinal cord and the vertebral disc space in that order. So he's very structured, and he follows the checklist to make sure that he doesn't mess up anything. The next solution is computer-aided detection, also called CAD. What this does is actually has a computer scan the picture of the lungs, like you see here, or it can be the spine or brain or anything. And there's areas that are highlighted that they want to bring to the radiologist's attention. So this is actually really cool in that it can help a radiologist to see something that might be wrong. But one of the downsides of this is that a radiologist might depend on these highlighted areas in the future and become dependent on it. The last is the double check method. This is actually the method that is used the least because of its fiscal efficiency. What happens is two radiologists will read the same scan and then have separate interpretations, and then those interpretations will be combined into one to make one project and one file so that they counteract each other's errors if there happen to be any. The last article that really impacted me the most was about how technology has or has not ruined the radiology profession. One of the biggest things in radiology is PACS, PACS. It stands for Patient Archiving Communication System. So what you can actually do with PACS is radiologists can pull up scans from the past, from patient files, or they can look at scans from a different facility to compare. What this can help with is, say you have a patient with a tumor. You can see the progression of the tumor or the digression of the tumor and see how it's getting better or worse without having to look through old file folders in an archive somewhere in a bunker. What this has done, unfortunately, even though it's such a great benefit to the patients, is stressed quantity over quality. Because radiologists can do so much work faster with PACS, a lot of physicians believe that they can cover more and keep doing more and more, reading more and more scans instead of spending the time and the effort to make sure that each scan is read properly. And Dr. Malloy, a radiologist that I interviewed last year from Centennial Medical Center, said that expectations because of PACS have risen exponentially. Another way that technology has helped and hurt the radiology profession is visual pattern recognition. Like the computer-aided detection that I talked about in the last article, visual pattern recognition uses computer software to detect any anomalies in a patient's scan. But what's scary about visual pattern recognition to radiologists is that it can actually detect what the anomaly is sometimes. For example, pulmonary emboli in the lungs, which is a blood clot in the lungs. And this is scary because it can actually kind of do the radiologist's job, and it's not good for the future of radiologists, even though it's terrific for patients. So this year I've had the privilege of starting my mentorship extra early compared to last year. My mentor is Dr. Connor Riley. He graduated from Texas A&M Medical School, and he specializes in neuroradiology, and he did that at UT Southwestern. He's with a group practice called the Radiology Consultants of North Dallas. It's very broad and has a lot of general radiologists and specialty radiologists. He works at clinics called Preferred Imaging. There's one in Frisco right here. There's one in Richardson. They're everywhere. And he also works at hospitals like Medical City of Dallas. Some of the most important things that I've taken away this year from my mentorship experience are that I want to specialize just like Dr. Riley, maybe even in neuroradiology because I've learned so much from him. I also want to perform some procedures just like he does. For example, he'll do some contrast injections under fluoroscopies to see how a joint fluid is moving around when the patient bends their knee or their elbow. I've learned everything about the spine and the brain you could possibly think of and more. If you asked me at the beginning of the year what Chiari malformation was or foraminal narrowing, I'd be like, are you talking Latin to me? Like, I don't understand what you're saying. But I know exactly what that is now because Dr. Ali's so great at explaining everything. One of the things I really valued was he talked about how we can improve radiology, and one of the needs is communication improvement between the radiologist and the referring physicians. He has sometimes a lot of trouble contacting people and getting them to contact back, or they don't pick up their phones or things like that, so we need to improve the communication. And that leads me to my original work. I knew I wanted to do three things with my original work. I wanted to benefit the three parties that are involved in radiology. That would be the radiologist, the referring physician, and the patient. And I wanted to elaborate on what I did last year, which was between the radiologist and the patient. So this year it would benefit all three parties instead of just the radiologist and the patient. And I wanted to address the issue that he gave me about the communication between the radiologist and the referring physician. So what I proposed to do was create a communication protocol. And what it does is standardizes communication between the radiologist and the physician so that communication can go much more smoothly and reduce the latent errors that are present in everyday communication. So the benefits of this were that it standardizes communication, and through that it decreases the latent errors, which are errors made through miscommunication mostly, or planning errors, or getting off topic. And one of the things that it does also is it saves time. Since the communication is standardized, there's a lot faster way to fast track through all these all the medical terminology and what the radiologist wants to communicate with the physician and so forth. This year in ISM has been great, and although I don't know what I want to do for my final product this year, I know on May 17th, 2017, I'll be looking back super depressed and super sad that it's all over through the thousands upon thousands of hours that I think I've done on research and the many thousands of tears that have gone onto my computer keyboard. I can say that ISM has been worth every second. Thank you.